Okay, I think we're good. Off to you, André.
Thank you very much. Everybody's there? Yes, good. So today it's another of our seminars, special seminars, I guess, where we asked people that have been funded by the network over the past few years to update us on their progress. So we've done that with people who had data science and health informatics awards. Now we're doing this with 3 individuals involved in the health technology assessment and related areas. And we're going to have the same kind of thing down the road with technology development awards. So this is obviously important for our reporting, but also it's important, I think, for the whole network so that people know what's going on. And of course, also as we embark in future phases, then there's going to be a phase 2 of this project. And in that phase, it's going to be very important to convert the work that we're doing into practice. And I think the involvement of people with health technology expert to enable in live as we go over the next 4 years to enable demonstrable integration into practice, reduction to practice will be crucial. So this is like, I guess, the start of the end of phase 1 and soon the beginning of phase 2, but we wanted to hear what you've done in phase 1. And thank you very much for coming to do your presentations. And Véronique, I pass this on to you.
Thank you very much, André, and welcome everyone. I'll start off with just a little bit of housekeeping. We will be keeping questions until the end. We have 2 presentations today, but we'll do questions all together at the end. So please either type your questions in the Q&A box at the top of your screen. It's the 2 little speech bubbles with the question mark. Or when the time comes during the Q&A period, you can raise your hand. You just press the little hand button that's 2 buttons over from the Q&A at the top of your screen, and then we'll allow you to unmute yourself to ask your question live. And so I also want to take a quick moment to acknowledge that I personally am calling in today from Mi'kmaq, the traditional and unceded territory of the Mi'kmaq people. Our network members and our speakers and our attendees today are located all across the country on lands that are home to diverse First Nations, Métis, and Inuit populations. And I invite everyone here today to honor and pay respects to those peoples and to reflect on the importance of the lands and waters that we all call home. Now I have the great pleasure of introducing my co-chair, James. James is one of the inaugural members of the network's patient working group and has been very much involved in a lot of different projects that the group has undertaken over the past 2 years. So thank you so much, James, for all the work that you do and for generously volunteering to co-chair this seminar. I will pass it to you if you want to tell us a little bit about yourself and then kick off the seminar.
Sure. Thank you, Veronique. Firstly, I'd like to acknowledge that I am on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I also acknowledge that Toronto is covered by Treaty 13 signed with the Mississaugas of the Credit and the Williams Treaties signed with multiple Mississaugas and Chippewa bands. Hello, everyone. As Veronique mentioned, I've been a member of the MOHCCN patient working group since its start. And I'm also a volunteer driver with the Canadian Cancer Society's Wheels of Hope program, taking people with cancer to their cancer-related medical appointments. As well, I've served as a patient survivor and caregiver reviewer with the Canadian Cancer Society for the last few years. Although I do have an undergrad degree in zoology and biochemistry and a master's degree in biochemistry and molecular biology and toxicology research background, since coming to Canada 31 years ago, I found my way into the performing arts industry. But like many people here, cancer touched me from an early age, having lost my own father to lung cancer when I was 24 years old, and several others close to me since then. So it gives me a great sense of gratitude that my life has found its way to the cancer research field in the last few years, and especially to the patient working group, the members of which lift me up every day and truly epitomize what I call the miracle of hope. And that's what brings us here today. So I know you didn't join us today to listen to me. So without much further ado, I'm honored to introduce our speakers for today. Our first two speakers are Dr. Yvonne Bombard and Dr. Timothy Hanna. Dr. Bombard is a Canada Research Chair in Genomics Health Science Services and Policy and Professor in the Institute of Health Policy, Management and Evaluation at the University of Toronto. She is also the Director of the Genomics Health Services Research Program at St. Michael's Hospital at Unity Health Toronto, and the co-founder and CEO of Genetics Advisor. Dr. Timothy Hanna is an assistant professor in the departments of Oncology and Public Health Sciences and a primary investigator in the Division of Cancer Care and Epidemiology at Queen's University, a radiation oncologist and clinician-scientist at the Cancer Center of Southeastern Ontario, and a clinician-scientist at the Ontario Institute for Cancer Research. Today, Drs. Bombard and Hanna will tell us about their network-funded project, measuring the quality and value of precision oncology care. So go ahead, Dr. Bombard and Dr. Hanna.
So maybe just as the slides are coming up, I'll acknowledge that I'm speaking to you from Kingston, Ontario, traditional lands of the Anishinaabe, Haudenosaunee, and Huron-Wendat nations, and it's a real privilege and honor to live, work, and play here. And also, again, to gratefully acknowledge the funding from the Terry Fox Research Institute, MOHCCN network, their donors in the federal government in supporting this research, and also Shifat Ahmed for preparing a primary draft of these slides. So we'll just jump into it. All right, so I'd like to provide a bit of background on this work. To remind you, precision oncology is a way of delivering care that offers treatment tailored to individuals' cancer context and tumor characteristics using comprehensive genomic profiling as one of the more cutting edge and latest ways of doing this. Currently, precision oncology is evaluated largely focused on technical and clinical measures with less of a focus on process-based measures and outcomes that reflect patient values. Right now, when we think about measuring quality of care, metrics that relate to precision oncology typically relate to common cancers and also to single gene alterations rather than comprehensive genomic profiling approaches. We're missing broader dimensions of quality that matter to patients, like understanding genomic information, so that's a communication aspect, patient aspects of access to testing and treatment, and also results delivery experience, so making sure that the information is understood and communicated in a patient-centered way. So how can we address these gaps? By identifying a set of patient-centered indicators that are specific to precision oncology and applicable across cancer types, testing, and treatment technologies, we can better measure and improve quality. So we've set out to undertake a collaborative and consensus-based approach involving patients and clinicians to measure and improve care in precision oncology. And I'll say that this process is starting with talking to patients, and then based on what we learn, we are going to go into a consensus building process amongst clinical experts to prioritize key patient-centered measures of quality. So let me take you through a little bit more about what quality means. Don Abedian described the measurement of quality in terms of the structure of care, and that relates to the buildings and institutions that the care is provided in, the technology and the people that are there to provide the care. And then process relates to how the care is actually provided. And you need those structures and processes in place to lead to optimal outcomes. Now, the Institute of Medicine describes specific aspects of quality of care. For the care to be of the highest quality, it needs to be efficient, it needs to be safe, it has to be effective, it has to reflect patient-centered values. that care also has to be equitable and accessible in a timely fashion. So you can see there's many different dimensions of quality that have to be considered when we're aiming for improving outcomes. So when we're thinking about how quality fits into health technology assessment, it's an overlapping concept. For us to have optimal care, which sits at the center of what we do, people need to be able to access that care. That care has to be high quality, and we have to select the kind of care that would be optimal for people to receive using health technology assessment. So I'll hand it over to Dr. Bombard that will take you through some of the methods and get into some of our early results.
So this is a mix. Thank you, Tim, and thanks to the organizers for including us in the program today. So I just wanted to quickly say that this is a mixed method study that Tim and I have the pleasure of leading. And I'm starting out with a qualitative piece and then handing it over to Tim to take forward for that quantitative survey consensus for the building process. The qualitative piece is semi-structured interviews that are going to be conducted with cancer patients who have had genomic profile and have received results, so they can think about some of the process structures as well as outcomes of the testing on their care. The target will be interviewing 60 patients, 20 from Quebec, 20 from Ontario, and 20 from BC. And we are using an interpretive description approach to analyze the data along both the quality outcomes that you just saw in that diagram, the access issues, as well as what are the health technology assessment outcomes or value, that how to just value that. So just an overview of the method. So I'm going to actually start off by presenting some of our preliminary findings from the first 15 interviews we've conducted, and just orient you to the wonderful group of 15 individuals that we've had the pleasure to talk with. Their characteristics are as follows. They've mostly come from Quebec and BC at the moment. Our Ontario interviews will kick off this month. But these wonderful participants who've donated their time actually reflect mostly females, aged 40 to 64 years of age, roughly. They are a preponderance of advanced stage disease patients, which reflect the provision and mostly the eligibility criteria of the network's programs, which usually provide the advanced sequencing to, the sequencing advanced patients. But we do have some representation of diverse cancer types, giving us some perspectives and diverse opinions. In terms of ethnicity, and as seen in lots of the research in this space, unfortunately, there is also a preponderance of individuals who self-identify as white and of European descent. And there are ongoing efforts to try to diversify our recruitment strategy so that we can also diversify the perspectives that we're hearing from other folks. But from our preliminary analysis to date, we have a lot of themes that are emerging. And what's different with qualitative analysis and method design that's different than quantitative that you all might be familiar with is that we collect our interview data and analyze it as we go. Because often what we're trying to do is optimize the subsequent sampling, recruitment, as well as discussion so that we can gain more depth around areas that are not hearing a lot of topics or at least saturating those themes. So this is quite typical and good practice to be analyzing data as we're interviewing. And so these 15 interviews have already identified rich themes that are already popping up and mapping onto the quality framework that Tim has just described. And I'll unpack these in turn, focusing on the top half of the circle and then moving to the bottom. So first, when it comes to efficiency, themes about efficiencies revolved around access to the test reports as well as understanding the nature of them. So in terms of result comprehension, there was contrasting perspectives about access to the test reports and understanding them. Some patients wanted full access to their reports. They wanted to deep dive into the details using AI tools and online resources for self-learning, while others really actually wanted sense they could self-make of these technical reports. And they were they're happy to rely on the provider who just form the significant findings emerge. And this is an example quote on the left here when one patient speaks to the latter. I've learned that poring over my scans, Googling every new treatment just doesn't help. Right now, my just doing their jobs vis-a-vis telling me when there's clinical findings, just trying to live my life and not give the disease any more space and time that it already takes. When it comes to the delivery of the sequencing results themselves, patients actually, again, none of them had actually experienced receiving any of those results through a sort of patient portal. But here too, we had mixes of patient practice. In the higher age demographics tend to prefer printed reports or low-tech opportunities, while the rest actually would prefer accessing test results through online tools, much like they have access to their other work. When we talk about effectiveness, some themes are merged, build up on this. Obviously, is very much classically dependent on the companion diagnostic sequencing, opening up opportunities to druggable targets or targeted therapies. And here, for some patients, understanding or even calling the implications of the sequencing on treatment decisions was challenging for patients, especially if they were on multiple therapies or dealing with comorbidities. And so it's difficult for them to pinpoint exactly how much the sequencing shaped their treatment decisions. But when it was clear and patients were informed that there was a druggable target that was found in the sequencing, and it led to either new option or confirming existing treatment plans, they absolutely saw the value and appreciated the effectiveness of it. And here you can see that one of the patients actually characterized the testing as finding the quote-unquote Achilles heels of their cancer. When patients reflected on safety and issues of safety, this really involved around discussions of side effects and how those were traded off vis-a-vis the benefits, the clinical benefits from the testing as well as the treatment. And here patients really valued small improvements in symptom alleviation or even well-being, which were very meaningful, and to them very much traded off potential negative side effects, which they had help understanding and helped them set expectations in advance. When it comes to the latter part of the element of structure and process, when it comes to equitable access to the testing, here participants, when other kind of equity barriers started to emerge for the interviewees. Patients reflected on potential challenges in navigating care and accessing information for people for whom English either isn't their first language, or they're not proficient in English, or have limited digital literacy. And of course, they also reflect on the fact that these are not specific to genomics or precision oncology, but this are broader issues with health system and service delivery writ large. I'll come back to equity and access in a moment. But when it came to patient-centered care, two other themes emerged that sort of resonated and mapped onto this idea of patient-centeredness. And patients really spoke to the responsiveness of the care that they received from their teams. So patients felt actually very supported by their providers, and they often spoke about how important it was that they felt that their concerns were heard by their care team and treatments were adjusted where possible. And as we see in this quote, the feeling that the care team is doing as much as they can to make their care more, then the treatment more comfortable was of paramount importance here. Also, patient centricity, the patient friendliness of the sequencing report itself was something that was actually quite challenging for patients. Patients felt that the genetic test summaries themselves were very long, filled with technical jargon. They asked for more patient centricity and accessibility in these reports, including summaries, implications for care, similar to the way that other test reports that they receive in their cancer care. Patients, these reports are not constructed for a patient audience. I spent a lot of my time using AI to unpack what a lot of this stuff actually meant. I'd say I spent dozens of hours really trying to understand this one paragraph, its implications, its possibilities. With regard to timeliness, there was two themes that emerged that made this dimension of quality care, timely care. And first was wait times. With regard to timeliness, most patients received their results anywhere between 2 months or 2 to 10 months with support from research teams. And patients actually acknowledged that they had a lot, made aware there could be a delay, and this was part of the research, and part of a research study with possibilities that they receive actionable findings, and that themselves help manage the anxiety during the wait period. And this talk, and specifically this quote at the bottom, talks about, this patient, I didn't know how long it was going to take to receive the finding, but I was with the cancer. I talked over time, and it was very helpful. So I had the wait time long, but that there is auxiliary support and staff in the interim, whether it's by people or other some resources, was critical in order to play the challenge with wait time. Now, timing also came up when patients actually wondered whether sequencing and genomic profiling can actually be introduced earlier in their cancer journey and not wait until stage 4 or later, because they had expected it to spare them from less effective treatments and actually save them time and some of their side effects. For example, this patient saying, I think they should consider it genomic profiling at stage 3, not just stage 4, because that could have suggested that drug A might not have worked and instead went straight with drug 2 right from the start. So I presented some of our preliminary data on quality. So going back to this diagram, I'd like to briefly share and illustrate how this idea of quality, access, and the value through HTA are actually emerging and interrelated. So with regard to early data that we're getting around the HTA outcomes of value, there was definite clinical decisional outcomes from sequencing that patients did value. They described how undergoing genomic profiling helped them better understand their cancer, provided them with clarity and information of their treatment plan. They, of course, valued when the profiling identified targeted therapies and options for clinical trials. For example, you can see at the bottom that sequencing, this patient said they did find a drug based on my mutation of one of my genes that seemed to be a result of having the tumor sequenced. So there was both the value ascribed to the sequencing as well as the clinical utility and treatment opportunities that, and not the direct attributable to the sequencing. Beyond clinical outcomes, patients associated personal value. Sequencing especially when it helps understand hereditary risks. Now we can appreciate that hereditary risks are not only good and potentially useful as a personal utility or from a information, has clinical benefits to the patient in terms of further targeted therapies and PARP inhibitors, as well as cancer prevention opportunities for the rest of the family members who haven't been tested. But also the sequencing can provide emotional benefits like closure by reducing uncertainty, and then the satisfaction of knowing that there's no treatable, viable option that a bit left on the table, as exemplified in this quote. My genome testing is done, and if I hadn't had it done, I would have always wondered if there was some information I could have helped. And finally, as we know from our patient working group and others that we have the opportunity and honor of working with, that patients really value the opportunity to contribute to research and the opportunity to help future patients with similar cancers, even if they themselves don't have immediate benefit from the sequencing, if it doesn't offer any therapeutic opportunities. And then finally, I'd like to just point out that actually access and equity issues interspersed across all dimensions. So just to reiterate, as Tim mentioned off the top, while understanding quality of care understands the how, the process, and understanding HTA, understand the outcomes of value, whether it's clinical benefit or a value for money in terms of bringing these technologies into practice. But our conversations with patients also show that the value may be experienced or perceived differently by different patients based on access issues. So let me explain with these 4 emerging examples. First, patients talked about how they experienced distress when sequencing did not provide any new information on their tumor, leaving them almost with no treatment options or contributing to a sense of being less visible or prioritized by the health system. Here, this patient said, the reality is there is nothing more that providers can do. I'm no longer being followed. I'm no longer of interest, if I can say that. And so this underscores the importance of managing expectations and communicating non-actionable results with care, given the potential psychosocial impacts that the sequencing and the lack of opportunities for therapy provide. Now, this was a strange interplay between access to trials and therapy. patients shared concern that information for genomic tests could actually identify mutations that would make them ineligible to certain therapies or trials, options that might have been open had they not had the testing and available to others with the same cancer. So again, it amplifies concern. I did have concern if doing genetic testing identifies my mutation wouldn't be responsive to the treatment, and that excludes me from even trying certain drugs, for instance. So this speaks to the perceptions of unequal benefits shaping patient value genomic sequence and access. Information sharing. Patient just attention around information, and here the quote talking about the participant advocating for, transparency and sufficient access to information, but also acknowledging that be too much information that can confuse patient and lead to patient anxiety. And again, this is a delicate balance, how access can determine value, but also can actually create disvalue for patients who are overly anxious and don't have the right interpretation of what results. And then some interesting equity and access questions came up when patients started to actually question whether or not they should be giving up their patient sequencing themselves, especially early on in the cancer journey, highlighting the value that they place on comprehensive genomic profiling, but also simultaneously recognizing that the ability to not learn who fits. So all these areas have access are not separate, but rather cross-cutting themes and factors that are central to how patients perceive and value the sequencing, as well as structural issues in terms of quality of care and the way that we deliver it. Just to wrap this up in summary for our preliminary findings to date, with regard to the HTA dimensions, absolutely the sequencing and profiling is valued by patients, especially the treatment planning to informing care and hereditary risks, as well as research contributions. Quality in terms of that dimensions, we're seeing timely communication, comprehension of results, the delivery of those reports being a challenge for patients, really highlighting the need for patient centricity and accessible delivery methods. And here there's a lot of patient heterogeneity preferences, really, so reinforcing the importance of flexible, different approaches for patients to gain entry and make use and full value of the precision oncology testing that we're providing them. And finally, with regard to access and equity and access, here patients are questioning whether we can integrate profiling earlier into their cancer journeys, and also, setting the importance of setting expectations of how the profiling, the tests actually might influence access to therapies and to trials. And so that those expectations, patient experiences, and those outcomes can be optimized. And that's very important if and when we scale up to phase 2. So the next steps of our work will be to build out the rest of the qualitative data and then move into the quantitative Delphi surveys to reach a consensus on what are the core outcomes and for the quality metrics, as well as the HTA value metrics, so that these can be then built into the data models to the prospective elements of the next phase of the Marathon of Hope. I just wanted to quickly shout out again both the patients who are extremely indebted to their generosity in sharing their experiences and experience with us, Shafat Ahmed for driving a lot of data collection, and this was as Jeanette, George, and Aziz from Vancouver, Montreal, and Toronto, who've been helping with participant recruitment. That's it. Over to Dee.
Thank you, Dr. Bombard and Dr. Hanna, for that promising and exciting update. So our next speaker is Dr. Dean Regier. Dr. Regier is an associate professor at the School of Population and Public Health and director of the Academy of Translational Medicine in the Faculty of Medicine at the University of British Columbia. He is also a senior scientist with the BC Cancer Research Institute. Today, Dr. Regier will tell us about his network-funded project called Platform for Regulatory Science, Innovation, and Equitable Health Systems. Go ahead, Dr. Regier.
Thank you very much, James. Just confirming you can all hear me. Is that a yes? Nod?
Yes.
Yes.
Perfect. So thank you so much for the opportunity to present some of our results from our platform for regulatory science, innovation, and equitable health systems, which we call PRISM. So anytime throughout the presentation, if I say PRISM, I'm referring to this platform. And broadly, the platform has been built out, I guess, for over 9 years now through our regulatory science lab at the University of British Columbia. It is funded by the Marathon of Hope, and all these great people here, including Genome Canada, Genome British Columbia, Tri-Council, Health Research BC, and the AI Health Research Network at UBC. And I think more importantly, I'd be remiss to acknowledge that my co-authors on this presentation and the leadership of my lab include Deirdre Wyman, who's the program head of evidence within the regulatory science lab, and Emmanuel Krebs, who's my program head of economics. And then finally, just one more kind of leader, Dr. Samantha Pollard, who's not in the lab anymore. She has her own lab now at BC Children's Research Institute, and is faculty at Simon Fraser University, has done a lot in terms of shaping how we think engagement around patients and populations. And so I thought I'd level set a little bit here with respect to access and reimbursement of precision oncology, and why it's sometimes challenging to have access to novel precision oncology interventions and the omics that support them. And broadly, the reason for this is this idea that's been proven over and again that precision oncology, because it personalizes treatments to patients' pathophysiology in a tumor agnostic setting, challenges regulatory and reimbursement pathways, challenges the traditional ways that we think about the evidence needed for regulatory approval and through paying for it in our healthcare systems. And this is owing to a few things, including small benefiting populations. As we have the greater personalization of care, what we know is that you subtype and subtype and subtypes, and these populations become small, which make it very difficult to conduct trials. And these trials are absolutely necessary, particularly randomized controlled trials, are absolutely necessary to draw a line between an intervention, for example, whole genome transcriptome analysis, and the outcome, which is overall survival, quality of life, etc. And because precision oncology has small benefiting populations, the traditional trial designs, like a randomized control trial, are not typically used. In fact, single arm basket or umbrella trials are most commonly used to understand things like progression-free survival, which makes it very difficult to answer those questions around overall survival. And then finally, a big challenge in evidence around precision oncology is this concept of surrogate outcomes. So surrogate outcomes like progression-free survival. A surrogate outcome includes how many patients have a treatment change based on the genomics report. While those, as we just heard, are very important to patients, they are poorly correlated with things like overall survival. And they're also poorly correlated with traditional notions of health-related quality of life. And so the challenge of evidence in this case has led to uneven access precision oncology interventions across Canada. And I don't have time to go into, so this is emerging work that we're doing, trying to map out how many biomarkers are tested in our oncology systems across Canada. But what we do know, and what seems to be appearing through our heat map, is that there's uneven access across provinces, across jurisdictions with respect to single gene testing versus multi-gene panels, which is next generation sequencing, and of course with respect to whole genome, things like whole genome sequencing, transcriptome analysis, which is not, to my knowledge, really widely reimbursed through Canada. And so this is what PRISM, this platform, is broadly meant to start generating evidence for, with respect to answering a simple question and addressing a simple mission, which is how do we accelerate discovery through our learning healthcare systems, through concepts related to what we'll call regulatory science, with a view of delivering patient outcomes and economic impact faster. So we want to accelerate access to safe, effective, and cost-effective technologies. And the reason why we do look at cost effectiveness is because it's really important, the sustainability of our healthcare systems, access for all patients, not just cancer patients, is a really important conversations as we allocate our scarce resources across different components of healthcare and society. And so I'm going to unpack one aspect of the mission statement of PRISM, which is this idea of learning healthcare systems, which is just a simple idea that says, well, how do we embed discovery as a part of everyday patient care to ensure safety and efficacy? And so learning healthcare is a way to get new technologies to patients faster, but to build the evidence base as we gain more experience, as we gain more understanding around the outcomes for that intervention that we are trialing. And so we have published, and we've talked about a few times in this forum about, we think that learning life cycle assessment is learning healthcare system, which is our concept of how do we standardize real world study design, data access, data curation, data abstraction, and the analyses needed to guide the appraisal, reappraisal, and de-adoption away from previously high value to low value technologies. And this circle that you see on the screen, I won't get deep into the various components of it, but the first component, which we've labeled A, managed access, is allowing timely, quick access to a promising yet unproven therapy that's supported, for example, by an omics technology. Then we collect that real world data as patients experience the trajectory that is caused by that intervention. We collect those outcome data and the cost data. And then importantly, we join that or concatenate that with external data sets. Now that's important because of the small benefiting population concept, is that we need to find a signal of effectiveness, of benefit, if a signal does exist. And a lot of that time, that's a sample size problem for us, particularly in the tumor agnostic setting. So what we do is we join, like a Marathon of Hope Cancer Centers Network concept, is we join our data, for example, in British Columbia, with external data sets to amplify signal if it's there. And then we do something called real world evidence analysis. And we'll get into a little bit what I mean by real world evidence in a moment. So the aims of the platform are, for the purposes of this talk today, twofold. We want to validate, and we want to do science. So we want to validate causal real-world evidence to accelerate access to precision oncology interventions. And we want to deploy and evaluate, because part of real-world evidence is real-world data of learning healthcare systems. We really need quick and accurate extraction of data to support our real-world evidence generation. And so we're doing this and trialing this through large language models and artificial intelligence. So I'm going to start with the real-world evidence aspect of it. And so as I mentioned, randomized controlled trials are the gold standard to evaluate a causal effect between an intervention and an outcome, like overall survival. We don't have RCTs typically in precision oncology interventions. So what we're doing through PRISM and through my regulatory science lab is we want to emulate a randomized controlled trial through something called target trial emulation. Now, the benefits of target trial emulation is it allows us to address things like bias, like confounding bias, which occurs when treatment and control groups are not randomized, and there's some unmeasured factor, or a confounder, that is common cause of both treatment and outcomes, which really makes it impossible to disentangle a true effect of an intervention on the outcome. And the second type of bias that we're really trying to address here is this concept of immortal time bias, which is a type of bias that occurs when there's a period of follow-up time during which patients must, by definition, remain outcome-free. So they're not at risk of death. And so this idea of target trial emulations is we emulate the ideal pragmatic randomized controlled trial to actually mitigate these well-known, well-established observational study biases. And if we do that, and this is really important, if we do that, we can actually make claims that we have a causal relationship between intervention and outcome, which we know time and time again, regulators and health technology assessment agencies that make recommendations about which technologies to reimburse or not, they really need to see that causal link between an intervention and outcomes. And so here is some work out of PRISM and mine and Tim's network called the Canadian Network for Learning Healthcare Systems and Cost-Effective Omics Innovation. And I won't go too much into detail here, but we use a target trial emulation to answer the question of what if we were to use a multi-gene panel, which in this case is OncoPanel in British Columbia, versus a single gene test. Is there any benefit to it? The hypothesis is no, and the reason for that is that the single gene test should theoretically, or I guess at some levels, be almost as good as finding a variant that is joined with as treatment change, almost as good as a multi-gene test. So we were saying, well, multi-gene testing we've implemented in British Columbia for colorectal cancer, non-small cell lung cancer, and melanoma, and was that beneficial at all? And so we use target trial emulation using this study design on the left. And what we found actually was quite illuminating. When we looked at the multi-gene panel versus single gene testing, we found that there was indeed an overall survival benefit with respect to through the hazard ratio, and that was statistically significantly different from 0 in the tumor agnostic, so across the tumor indications for advanced cancer. And crucially, we also found, and this is I know the bottom right is like a weird plot that has a whole bunch of dots on it, but what it tells the economists and what we would communicate in the deliberation, it's also cost effective. Anything you see those rays, those vertical rays from the origin, and all those dots below those rays are considered to be cost effective, and some are even cost savings. And so what we found that things like precision oncology, at least through next generation sequencing panels, can be improve life, can improve overall survival in this causal relationship world, and also are cost effective. And really what this, and we haven't published this yet, but what this will do is will lead to universal access to multi-gene next generation sequencing panels across Canada to try to even it out. And so what we are doing now in this context for the Marathon of Hope is use things like case studies like the Personalized Oncogenomics Program, POG, led by Mark Amaro and Janas Alaskan. We're doing this with POG in a way to use the same types of frameworks, the same types of target trial emulation to move forward with that causal inference around effectiveness and cost effectiveness. Now, the second part, research question that we're asking is like, what data? Like, what data do we need? And just to be like totally honest, like cost effectiveness analysis needs all the data in terms of the clinical data, the health services data, and the cost data. And so through various programs generously supported by, I guess, over like $20 million investment over the last 10 years, is that we have developed an internal ecosystem within British Columbia that allows us to have all the types of data that we need around clinical outcomes and cost outcomes and health services outcomes. And we put that into this database, which is on the left. It's represented by this dashboard. We have over 172,000 patients, 1.5 million years of patient follow-up, 27,000 results from single gene or multi-gene testing, and through POG, over 1,000 data points with respect to patients through with whole genome transcriptome analysis results. And on the right is a causal network. It's a directed acyclic graph. And what this directed acyclic graph tells us is like, where are those biases? What data do we need? What data do we have? What data don't we have in order to address those biases that we need to address in order to find a causal relationship between precision oncology intervention and the outcome of overall survival? So this is how mathematically, visually, we think about it. And what we find, and we have a core outcomes data set for economic evaluation, is that we don't always have this data. And so what we've been doing is we've been creating and experimenting with large language models that help us get into electronic health records of patients and to actually extract that data, all that clinical data that's in the EHR, the data that health services data that's EHR. So we don't have to manually abstract it. So we can quickly do it. And why this is really important is we want to update our evidence monthly within our server and within our ability to generate information that decision makers can actually use. And so I won't get too much into the methods here, but the idea is that what we did is we used the Personalized Oncogenomics Program Outcomes Dataset as a gold standard to manually abstracted data. And then we deployed a couple of large language models to say, okay, can those LLMs replicate the human abstracted data? And we had a target accuracy of around 85%. And so here are some of the data points that we abstracted, that we compared. And what we found is that we were able to, after some fine tuning, and this is the commercial large language model that we used, after some fine tuning, we were able to achieve benchmark accuracy for all features. And this data included, well-defined dates and also demographics identifiable in clinician notes. So that was really nice to see, but crucially, commercial large language models are expensive. And so we had deployed our own in-house large language model to look at that accuracy, and this work is ongoing, using a 32 billion parameter model. And then without any adjustment, we are actually getting for, what you can see is sex, date of birth, age of diagnosis. We are getting and meeting our benchmark accuracy with respect to large language models that we can deploy in-house to abstract the types of data, which is obviously really important for the Marathon of Hope Cancer Centers Network, as we want to prospectively collect the data. And even with the retrospective data, how do we move forward to accurately get the types of data elements needed for not only the health technology assessment core data set, but obviously, and more importantly, for the clinical outcomes core data set. So I have 1 more minute, and this is my last slide, thankfully. So just broadly, how we look at this is that through collaboration, we want to simplify data capture and access using the approaches like large language models, like target trial information, to find new ways to create evidence and to share crucial information across health systems. We are deeply passionate about fast tracking access to precision oncology that is safe, effective, and cost effective. And we need the types of evidence in order to do that. And we need that evidence quickly, right? And so we really feel like the frameworks that we've been creating through lifecycle assessment create the opportunity to do that. And then quickly transitioning innovations. I did talk a lot about our equity analyses work, but how do we get the right types of data to answer those really important equity questions? And that's part of the overall federated learning, the synthetic data generation that we will pursue over the coming months, and then of course, engagement with patients. And speaking of patients, we are thankful to patients, to the Marathon of Hope. I am thankful to these key collaborators and my regulatory science lab. So with that, I'll stop sharing.
Thank you so much, Dean. That was a fantastic presentation. And both were really, so thank you to all the speakers. Just a quick reminder, if you do have a question, you can either type it in the Q&A box, which you can reach at the top of your screen, or you can raise your hand, which you can also reach at the top of your screen, and we'll allow you to unmute and ask your question live. But I think James has a question to get us started.
Thank you, Veronique. So just a quick question for Dr. Ridier. If you could kind of answer this more from a lay perspective. Your study looks at equitable patient access to healthcare. Can you elaborate a little more whether that equity is focused on certain groups like gender, race, socio-economical status, geographical location, or just the access to healthcare, or those studies or the testing based on province?
Yeah, that's an excellent question, and I was hoping that I get a question like that. So there's two. The short answer is yes. I didn't present it in this context, But in other slides, which we can do at a future date, we do something called distributional effectiveness analysis, where we look at different equity-seeking communities, populations, and we look at the degree of access they have as a community compared to the degree of access of the entire population. And then we plot that on a graph that shows the inequity of access to sequencing, for example, in comparison to its cost effectiveness. And a lot of time, particularly we do a lot of work in the indigenous space through something called silent genomes. A lot of time we actually found that we can have both an economic impact, a positive cost effectiveness conversation, and that also moves equity forward. And so what I'm finding is that the economic conversation is adjunct and can be used to contextualize the equity conversation. But I would just say this one more thing is that data around certainly things like sex, where people are in provinces or in Canada, are pretty easy to abstract. Things like ancestry, identification around sex and gender, those are harder things to tease out. And part of our large language model, part of this PRISM platform, is to actually get those out of EHRs if they exist, right? To start to fill in some of those blind sides in data that we know we have in our healthcare systems in terms of routinely collected data.
Thank you.
André?
Yes, hi, very nice presentations. I have a question for you. Dean, maybe it borders on philosophy, but I don't think so. So I used to be an oncologist, but now I'm a basic researcher. So I look at data all the time, but different types of data than the ones that you're talking about. So I wanted to know whether there was any consensus, either within Canada or a Western world or otherwise, about not just statistical significance. I mean, we all know p-values and all that stuff, the tests, but about survival improvement significance, quality of life, economical impact. I mean, do we, saving 5 cents would not be a real, so what are the metrics where people start to think that this is really significant improvement?
That's an excellent question, and it's a philosophical question with respect to both statistics and decision making. And so maybe I'll answer the statistics question first. Typically in economics, and particularly in health economics, we don't adhere to what we call frequentist statistics, like p-values. Although I will present p-values, we present things more in a Bayesian, or think about more in a Bayesian framework, which will have all my frequentist RCT friends mad at me. But the idea of the Bayesian framework is just ask a question. The question is simply
what framework?
A Bayesian framework.
Oh, Bayesian. Okay,
yeah.
Got it.
Yeah. So when we do a Bayesian framework, we ask a simple question. And that question is what is the probability that this intervention is effective and cost effective, which is totally different from frequentist. And what we actually do in terms of decision making, and I'm part of these decision making committees in Canada, is that it's not it has to be 95% likely that it's going to be effective or cost. That's not part of the economics framework. What we typically do is if it's, because we have a joint uncertainty around costs and outcomes, right? And so if that a probability is above 50%, then we say that's actually a pretty strong signal of benefit in terms of value for money. So if the probability is above 50%, then we say there's strong indication. And then we might also ask another question, which we do, is at what price makes it cost effective, right? So if we don't have a strong signal of cost effectiveness, we say how much does the reduction in price need to be, right? And so not to say that, and I don't want to say that economics is the be all and end all of health technology assessment. It is not. It is, as Yvonne and Tim mentioned, it's one part of a deliberation. But how we use economic evaluation is just to understand at what price will make this sustainable. The value question is patient's value, right? The implementation question is, can we do it in the healthcare system? We are one part of it, but philosophically, we have a higher tolerance for uncertainty in deliberation when we make our recommendations around value for money.
So what's considered a survival advantage, like 2-3 months, something like that, 3-4 months?
I mean, we find cost effectiveness probably around the 2-month mark, although the cost effectiveness has been proven around, like, depending on the price of it, could be like 3 to 6 weeks, just in my broad experience. Yeah.
Okay, let me flip this completely around. And so this is like my own bias. If a family member had a cancer, or if I had a cancer, we're human beings. So I think whatever the cost doesn't matter. If there's a treatment available, I think it should be given. So how prevalent is this view, and what's the answer to that?
While it is absolutely right as a clinician, as a patient, as a family member to demand the best therapies that are safe and have efficacy and effectiveness, and that's really important. The other thing to important is that, like, we have limited resources. We have limited oncologists. We have limited nurses. I'm not talking about budgets. We actually have a lot of money for our healthcare systems, but we have limited people to do these things. Genetic counseling is a really prime example, right? Returning results is a really prime example, right? And so the question is, how do we allocate those resources in a way that allows value for all patients, oncology patients, but also patients who are not suffering from cancer or suffering from heart disease, right? So philosophically, it's absolutely right to state that, like, this economics thing is, like, not great. And I deeply like understand that. On the other side, as a decision maker at the Ministry of Health, you have to make those decisions balancing the resources and where do we put our clinicians, our genetic counselors, for example. So that remains an outgoing challenge. And again, economics is just one aspect of that health technology assessment conversation.
Do you want to explain Bayesian to the patients who are listening? What were you talking about?
So Bayesian analysis, Bayesian statistics is actually the way we think about statistics, right? So, or like probability, like it says, okay, well, I observed this, and like, what is the chance or what's the likelihood that this will actually exist? And then I'll observe something else. And then I'll update, like, okay, well, one day I observed this, the second day I observed this, and then you're like, oh, well, that wasn't quite like the other thing that I observed. Right, so you update what we call your priors, right? Your priors get updated to a likelihood, and then you have to say, okay, well, as for all my experiences, this is what the likelihood or the chance of something happening. Frequentist understands is totally different. It says, okay, I have this sample, what's the mean? I have this sample, what's this mean? I have another sample over here, what's the likelihood of it happening, right? So it's like, okay, if you have different samples, what's the likelihood that something will happen? Bayesian statistics is like, hey, based on your experience and the evolution of the evidence, what is likely to happen? It's quite different. I did expect that question, André. That's a hard question to answer.
Thank you for that. We are at the top, or 1 minute away from the top of the hour. We have a question in the Q&A that is a very broad equity question that is coming from Amber, who's on our team. So maybe we can follow up a little bit more internally on that, but it's about access in the North. So if any of the speakers would like to speak to that, maybe in the chat. We do also have a question from Rosaline in the chat, who says, currently most funding algorithms put drugs that require genomic knowledge as second line of treatment in the metastatic setting, and these are only a few specific mutated genes for which we have targeted oncology drugs. How do you see the work being done by the MOHCCN changing standard treatment in Canada? So two big questions. That was from Rosaline, and a question from Amber about how do we increase access to genomic testing and precision oncology in the North. I know people probably need to start dropping off, but if any of the speakers would like to take a very quick stab at one of those two questions.
Yvonne.
Yeah, maybe I'll just leave with some maybe thoughts and calls for broader calls for action. I think that we all just have to recognize that our research enterprise is so inextricably linked to the clinical healthcare access. So we have to appreciate that there is only, just very fundamentally, if I'm recruiting for a trial, I'm going to my clinical colleagues at the hospitals, and they're drawing from their rosters of patients that they see. If we want to broaden access to our research and our trials, we also have to be thinking about how we have to broaden access to healthcare to these communities, because that's the first line of entry to access to both healthcare as well as the trials and research opportunities. So I think that that's a bigger call to action as to how we have to be working in tandem with our clinical healthcare systems and colleagues to try to be pushing for research opportunities to the healthcare systems that provide their patients and the services.
I think you're cutting. Your speaking is cutting. The transmission is not good.
At the end there, yeah. But thank you, Yvonne. I think that's a great setup for as we move forward with phase 2 as well, with the major emphasis on increasing access and access to precision oncology, but access to also participation in research through the network and through broadening of the network. There was also a follow-up from Marco, a follow-up to Andre's question. Dean, is it possible that cost effectiveness varies across healthcare jurisdictions?
Yes, that's a very good question, Marco. And the reason for that is that, you know, we have, particularly if we have a tumor agnostic precision oncology like paradigm, is that each province will have a different, what I'll call case mix. Like there will be a number of patients with non-small cell lung cancer, and that case mix will actually influences the extent to which we are able to observe overall survival across the tumor indications. Because as we know, precision oncology in colorectal cancer is super duper highly effective, less so in things like melanoma, right? So there will be differing levels of effectiveness across the different tumor types, and the case mix in terms of who's involved in the analysis will be reflected in each province. Okay, so that's why like case mix is important. Secondly, different jurisdictions have different budget constraints. We know ministries of health have different budgets that they're allowed to allocate. And so the question will be, well, in your specific province or jurisdiction, like who do you prioritize? How are you prioritize? How are you thinking through this? And then I'll just mention one more thing. And this goes back to the equity question I got, is that we really need to be able to tease out the different equity considerations in the north, in Saskatchewan. I'm from Saskatchewan, by the way, so I was using this example. We need to tease out those various equity contexts within each jurisdiction. One size does not fit all, just like in Indigenous research, like Indigenous, it's like there's a whole bunch of nations and they're not the same, right? And we can't treat equity seeking populations in the same way. So we need to better data to better tease out those underlying dynamics across jurisdictions of those conversations around effectiveness, safety, and access.
I think we're going to have to wrap up there. We are a few minutes past the hour, but thank you so much to all of our speakers and to everyone who asked questions. Maybe we can see if we can follow up in writing or something to some of these questions that we didn't have time to get to. So yes, thank you so much to everyone who participated today. Thank you, James, my co-chair. And for everyone who attended, we had over 90 people today, which is great. And we'll see you again in a few weeks for our next seminar at the beginning of February. So keep an eye out in your emails for that. Thank you and have a great day, everyone.
Thank you.
Thank you.